Hello, everyone. Welcome to another episode of Let's Talk Hereditary. Welcome, Dr. Church, and thank you for being with us today. Today, we wanted to address a specific problem. We talked earlier about patients with FAP and what is the treatment for that. Today, we want to address patients who have had a total proctocolectomy and a pouch. So, Dr. Church, welcome and thanks for being with us today.
Thank you.
We wanted to talk a little bit about pouch issues with patients with FAP, but before we address the issues, we want to talk about pouches. What is an ileal pouch?
An ileal pouch is basically a man-made reservoir for stool. And in order to understand that, we have to remember what the normal bowel function is like. So as humans, we're designed to go to the bathroom once a day. Because we abuse our diet and lifestyle, we may go more or less than once a day, but the average is once a day. And that's achieved by having a reservoir for stool in the sigmoid colon, and then a chute through which to defecate, which is the rectum. In patients that have had a total proctocolectomy, they lose both of those. And what they end up with is just the small intestine. So in the early days, people used to just anastomose or join the small intestine onto the anus in an effort to avoid an ileostomy. And that was a bit of a disaster because there was nothing to halt the peristalsis of the bowel, and stool was coming down all the time, day and night. And the poor patients were going to the toilet 30, 40, 50 times a day. So then came the idea, well, why don't we create a reservoir by manipulating the small bowel and building what is actually a pouch where the stool can build up. And so patients only go 4 or 5 or 6 times a day instead of 50 times a day. And this is the pouch.
And when we talk about the pouch, when we think of pouches and rectums, what is the difference in function between both those entities?
Well, the main difference in function is the rectum is designed to squeeze stool out. So it has 2 layers of muscle, a circular layer and a longitudinal layer. And when those contract, can be quite a powerful force to push the stool out. So again, as normal people with a rectum and a colon, we shouldn't have to strain when we go to the bathroom. The rectum should do the work. Unfortunately, again, because we don't treat our rectums very well and our bowels very well, sometimes we have to help the rectum by straining, which is not good for us or our hemorrhoids. But normally the rectum should have enough force in it to push the stool out. The pouch just cannot do that. It has no expulsive force. And the pouch has to empty by gravity. And this is the key difference between what's normal and then what's a new normal for the patients when they've got a pouch.
Okay, so to divide our interview today, we want to talk about 2 different topics. The first topic is talking about the technical portion of an operation like that. So what are the types of ileal pouches that we could do to patients?
Well, there are 2 main ones. The J pouch, named for the letter J, where the end of the small intestine is turned back and stapled to the small intestine as it comes down. And so it looks like quite a long J. And that's easy to make. It works well. It's safe. And we do it with staplers. Another pouch that we make is an S pouch, where the bowel is turned back on itself and then back down again, so that there, instead of 2 loops in the pouch, there are now 3. And the end of the bowel is used to anastomose to the anus. There have been other alphabetical pouches, such as the W pouch and the H pouch, but they're really historical, and it's just these 2 that we use.
If you get a patient that had an operation in an outside hospital, they told them we cannot connect you to the bottom, and they asked you about doing continent ileostomy or a K-pouch, do you advise patients with FAP getting K-pouches, or what are your thoughts about that?
Well, as you said, a K-pouch is connected, it appears as a stoma, a flat stoma, and the idea is to make the pouch to hold the stool and then to create a spout that is continent. So when you cough or sneeze or just as you're walking around, the stool doesn't come out the stoma. So the normal ileostomy, which is the alternative to all of these pouches, is just where the bowel is brought out through the abdominal wall and you wear a bag over it because the stool will come out anytime at once. So it's incontinent. That's normal for an ileostomy. So by creating a pouch above that ileostomy and then creating a continent valve that stops the stool coming out, we have a continent situation where the patients don't have to wear a bag. However, with a K-pouch, named for the Swedish surgeon that invented it, you have to drain it with a tube. So you carry a tube around with you. When the pouch feels full, you go into the bathroom, put the tube in through the valve, and then drain it into the toilet.
One last technical note I wanted to ask you about. When we do the J-pouch surgery, there's two different ways we can connect the J-pouch to the anus. Sometimes we do a hands-on anastomosis, and sometimes we do a stapled anastomosis. When would you do each of those, and what is the difference in function?
Okay, so the original way the J-pouch was done was to strip out all the lining of the rectum. So the rectum is removed, there's a little bit left where the sphincter muscles are, and the lining of that area is also stripped out. And then the pouch was sewn to the hemorrhoid area, the dentate line we call it, where the anus starts, with sutures. It became apparent that the function after that operation was not quite as good. There was a tendency to seepage and to narrowing of the area. And at about the same time, these newfangled stapling devices came into practice. So we started using the staplers to staple the pouch to the hemorrhoid area. It involves leaving a little bit of rectal lining, maybe about 1 centimeter, maybe 2 centimeters. But the join up is safer. It doesn't leak as often as the hand sewn, and it works better, and there's less incontinence, and the bowels tend to empty much more freely.
Do you do that for all patients? You tend to go to a stapler, to a stapled anastomosis?
Well, the basic decision is, can I leave some of the rectal lining down there? And if I can, then I should, in my opinion. Mm-hmm. In FAP, if there's a big polyp sitting right down there, we clearly can't. And we have to strip that polyp off because it's only in the lining. And then we can pull the pouch down and sew it in by hand. So we have that capacity to do that. But if the lower part of the rectum is completely free of polyps, we can leave it there and join the pouch onto it. We don't want to leave too much, but we can do a stapled anastomosis and give the patient better function.
Always makes me think of our mission, make sure there's no cancer that's going to develop and they're not going to die from it, and also preserve quality next. So now when we're talking about pouch and pouch problems, what is the most common problem that patients might have after a pouch surgery?
Well, the most common problem is dysfunction. So the first thing to realize is, what is a normal function of a pouch? In the context of it not emptying automatically, and remembering that it has to empty by gravity. So when patients complain of a pouch not working, usually it's because they're going to the toilet much more often than they think they should. And although there is a range of frequency of going to the bathroom, patients that go 10, 12, 15 times a day are not particularly happy because they have to wipe their bottom a lot, they get a sore bottom, they get an itchy bottom, there may be some leakage, and just going to the bathroom that number of times stops you doing things that you want to do with your day. So there are a lot of different reasons why the pouch may have to be emptied that often. It's not normal for pouches. Patients with pouches should go to the bathroom between 5 and 7 times a day, with an average of about 6. And that's about normal, depending on how much you eat. So if you're going a lot, it could be because your pouch is partially blocked. It could be blocked by a narrowing of the bowel. It could be blocked by a twist or a kink inside. And it could be blocked because you've been eating the wrong stuff, and the big apples that you've eaten are jamming into the end of the pouch and not letting the stool come out. So there are a variety of reasons for dysfunction. Most of them are correctable.
Okay. When we also talk about pouch dysfunction, a lot of patients will show up in the office and they've been told by someone that talked to them on the phone or seen them locally that they have pouchitis. What is pouchitis?
Well, quite simply, it means inflammation of the pouch. So I think what you're asking is, what is disease-related pouchitis, where the pouch is inflamed enough to actually be a disease that needs treatment. And basic to the discussion of pouchitis is recognizing the fact that the small bowel was not designed to store stool. The colon was. So we don't usually get colitis or proctitis, it's inflammation of the rectum, outside of a disease. It doesn't just become inflamed for no reason. Pouches are different because the small bowel normally transmits the stool very quickly over the course of 2 or 3 hours. And so if you're asking an area of small bowel to act as a storage unit for stool, it's going to get inflamed because the bacteria that are not passing through are starting to multiply, they're starting to ferment the food, you're getting like a cesspool in the pouch. And the worse your pouch works, the less often the stool moves out freely, the more that's going to happen. So it's normal if we biopsy the wall of a pouch to see chronic inflammation. That's normal for a pouch. And quite often patients with a pouch, they get antibiotics, for example, for a dental procedure or something. Their pouch starts to work better magically, and then they stop the antibiotics and it goes back to baseline. So antibiotics can help pouch function by reducing the inflammation, but the inflammation is normal in a pouch. But you can minimize it by emptying the pouch efficiently. So the key, if you have a pouch, make sure it empties efficiently. You'll be happier, you'll go to the bathroom less often, you'll have less inflammation, you won't have the symptoms of pouchitis.
Last question for this episode. What is a pouch follow-up? So a patient with FAP, they got their surgery. How do you follow them up with time now?
Well, there are 2 things that we want to follow up after a pouch surgery. One is that residual bit of rectal lining that we've left to join the pouch onto. And even if we do it hand-sewn anastomosis and try and strip that out, quite often we'll leave some microscopic cells. So we want to check that join up, the anastomosis, 1 year out from the surgery, and then every year. So it's at risk immediately. The other aspect of the pouch that needs to be checked is the pouch body, and that's where polyps can grow. And we have to remember that every cell in the body of these patients carries a mutation in the gene that causes FAP. And so the lining of the pouch cells have that mutation, which in combination with fecal stasis or stool just pooling in the pouch, which is what the pouch is supposed to give us, produces adenomas. These don't start immediately. They start to occur 2 or 3 years after the surgery. So by about 7 years, about half patients with a pouch will have at least 1 adenoma within it. And the number of adenomas we find varies. Some patients have none. Some patients, the whole pouch is carpeted with adenomas, and we may need to remove the pouch. We also treat the pouch with cancer-preventing drugs, such as Sulindac, and that can be effective as well. But it's very important to check that pouch every year, initially because of that little strip of rectal lining, and then later on because of the risk of adenomas in the pouch. I just wanted to say something about the check itself. If the patient's had a stapled pouch, so stapled to the anus, then they can usually be examined in the office without sedation because it's not painful. They need an enema or 2 to clean the pouch out first, and we do this all the time in the office. With a hand-sewn anastomosis, the anus can be a little bit more tender, a little bit more narrow, and they may need some sedation to do an adequate examination. And an adequate examination is very important.
I think the most important conclusion I get is even after surgery, patients with FAP should remember they still need follow-up because the cancer risk is not 0% and it's not totally gone.
Exactly.
Thank you, Dr. Church, for being with us today. Thank you for listening today. Remember, if you have any questions or concerns, find us on social media or call us at the Y Center, and we'll be more than happy to talk to you and answer your questions.